All right, so we have assembled a crack team of panel respondents to answer the questions that you have given to us. And so these are taken directly from the cards that you submitted, carefully collated. We're not going to be able to get to everyone. I was very impressed by the level of questions here and the amount of questions. So I don't think we're going to be able to get to all of them, but I promise we'll try to do our best. So I just wanted to introduce the members of the panel. We've got Josefa Domingos, PhD, that you've met already. Actually, you've met pretty much everyone here already, but Cara Jacob, Parkinson's disease physician. Maureen Gartner, nurse practitioner at the center. Russell Sawyer, cognitive behavioral neurologist. And Kim Seroogy, PhD researcher in Parkinson's disease. So let me start off with a question for Dr. Jacob. Right from the beginning, I get her.
I feel like I'm on trial in here under these lights.
So Dr. Jacob, one of the participants here had a question about early onset Parkinson's disease, and how is early onset Parkinson's disease different from regular Parkinson's disease? And in fact, is Parkinson's disease one disease, or is Parkinson's disease many diseases? I think is a bigger question related to that.
Oh gosh, how much time do we have? No. So basic definition, early onset Parkinson's disease is defined as patients who develop Parkinson's at an age younger than 50. And then, so that's early onset Parkinson's. Now, the second question is a little bit harder to answer. So we do think that, as I'm sure many of you know, that patients present very differently with Parkinson's, right? And people have very different rates or changes regarding their progression. And so we have thought that Parkinson's maybe isn't one single disease, but perhaps is many different diseases that present similarly. And in the future, we may treat those different presentations in different ways. That would really be kind of a future of this field. So I don't know if that answers the entire question, but.
No, I think that's gets at the heart of it. Ultimately, that you know, there's Parkinson's is. I mean, if you look at the number of people in this room and you talk to them, each person with Parkinson's disease has their own version of the disease, and so it's so different from person to person. And so there are some commonalities between people who have early onset Parkinson's disease. It tends to progress a little bit at a different rate than later onset. But in general, there's a lot of similarities that everyone shares as well. And so those commonalities are that what we try to treat in our clinic. Very good. Thank you, Cara. This question is for Dr. Domingos. There's a question asking about exercise. All right, and they're wondering how good is the evidence that high-intensity exercise is better than moderate or low-intensity exercise in improving the underlying progression of Parkinson's disease.
I didn't get the first part of the question.
So, yeah, sorry, actually, it's so hard to hear up here. When you were giving me the directions to what to do, I couldn't hear either. So the question is high-intensity versus low-intensity exercise. Is there good evidence to suggest that high-intensity exercise is better?
Okay, so I think we just saw in the last presentation that obviously there's a lot of research that is still trying to compare this, and that it's really about accumulating exercise and the frequency. I think the strongest evidence, and if you read, it's that we have currently, and that should guide us. I think I would say good sense has to always guide us. But for now, the best research that we have will be really about the frequency and not so much the intensity. Of course, there is evidence in favor of one and the other, but I think it's still, there's no final decision on that for sure.
Okay, thank you. There were a number of questions for Dr. Sawyer.
Pass.
No, but I think this is a very germane question. So, Dr. Sawyer, in your talk, you mentioned that there are a number of medications that actually could be complicating the cognitive changes seen in Parkinson's disease. And a question that someone asked was, do those cognitive changes that are linked to long-term use of medications like antihistamines, like anticholinergics, do those improve once the use of those medicines are stopped, or is it a permanent change, or do we know? Maybe we don't know.
Yeah, that's a great question, and I think I'll take it in a little bit of pieces. So there's evidence that even a single dose of the medicine can throw off your cognition for a day, and this may be something where it's more the chemical reaction, whereas over time we have measurable brain changes that happen. Now the question that we as physicians and we as researchers are trying to figure out are, when is the line? When do you have, okay, you've stopped taking this medicine, it's very reversible, versus you've taken this medicine for 25 years and those brain changes are sort of set in stone? And that's a question that we're still asking, because I would say even 10, 15 years ago, it was thought that these medicines probably didn't have as dramatic as effective as they do. So the answer is we don't know now, but I think it's one where, regardless of that, we try and minimize the impact and hope for some sort of reversible cognitive change.
And so what do you counsel patients when they're on multiple of these medications, just as a follow-up question? But say they're on a bladder medicine that is extremely helpful for them. How do you weigh those pros and cons?
Absolutely, and these are how important it is to have a personalized relationship with the patient and the physician, because it's all balancing act. I'm not going to say, take away all these medicines that have really improved your quality of life and really include other aspects of your life. But I tell people that there's a reasonable chance that the medicines that we're talking about have a negative effect on your cognition. Now, it may be that we compromise and say, hey, less is more. There are alternatives to the treatment that you're on. I've worked with several urologists and bladder surgeons, and they've talked about alternatives for treatment, medication and surgical, that are options for people. And they say, you know, we just sort of, we as urologists address these as sort of, this is what we do first line, and we aren't looking into the cognition and looking into those side effects because those aren't what are being brought up to them. People come in and say, yeah, I'm peeing great, this is fantastic, or, oh, my allergies are so much better, this is great. So I always look at the list and I say, you know, let's make reasonable goals for you. If we can reduce some of these medicines, we know we're going to get some sort of benefit. So let's try to reduce what we can, and it's a balancing act. It's not, okay, these are 4 medicines, I need you to be off of these, otherwise we have nothing that we can do to help you with. It's really developing that relationship and finding the balance.
Excellent. Thank you, Dr. Sawyer. I have a question for Maureen Gartner. Maureen, one of our participants here was asking about the progression of Parkinson's disease, and in particular, they said the Parkinson's right now is affecting mostly their left side of their body, but they're wondering, will it also affect the right side of my body later in the disease course? And just in general, what can people expect about the progression of Parkinson's disease?
So, because it's a progressive disease, yes, it will probably definitely affect the other side with time. Interestingly enough, though, it seems to, the side that it starts on seems to always be that side that's a little worse. Am I good on that?
You are good on that.
So that's why, you know, you wouldn't just exercise one part of your body, right? You're going to exercise both parts. So the whole concept of movement strengthens both sides of your body.
Yeah. Thank you.
Pass.
All right, so I have a pretty easy question for Dr. Seroogy. There's a lot of question about what are the causes of Parkinson's disease. What do we know about what causes Parkinson's disease? So easy.
Yeah, the ultimate cause is unknown, but there are some more recent thoughts on this that are very interesting, and that the Parkinson research community is now accepting, and that is that Parkinson's may start in the gut or in the nose, right? And what I mean by that. So, for example, there are nerves down in part of your gut, in your GI, gastrointestinal system, that can be contacted by the environment. You swallow something, whatever you eat, and one theory is that if a pathogen gets in there, it will then affect the ends of nerves that impinge on the lining of the gut. And those nerves contain alpha-synuclein. Remember the protein I told you? And what happens is that pathogen somehow corrupts the normal alpha-synuclein, misfolds it, turns into abnormal clumps. These clumps then are transported backwards up through the nerve, all the way up into the back of the brain. all right, where it then gets out and then connects the next nerve in the chain. Nerve cells, as you may know, are all connected with millions of other nerve cells, but in these pathways, so it gets out, it gets into the next nerve cell, and that corrupted alpha-synuclein then corrupts the good alpha-synuclein. So it's a kind of a vicious cycle that keeps going on and on until you get up to the middle, the bottom part of the brain, to the dopamine cells and other areas, but mainly the dopamine cells. And that ultimately, as it's progressing up the brain, this toxic, this abnormal protein then causes cells to degenerate, causes them to misfunction and to degenerate. And that's one of the thought to be some of the initial causes. The same thing in the nose. It's thought that, you know, you smell through your what's called the olfactory system. Anyways, these receptors in there. Somehow a pathogen gets in there, corrupts the alpha-synuclein, and that's transported in its key to the olfactory bulb and then back into your brain. And that can account for other symptoms of Parkinson's. For example, that'll go to your more cognitive centers in the brain. And that can account for some of the other symptoms of Parkinson's that are not motor related, but more, you know, thinking related and depression related, for example. So that's kind of the main thinking right now of how it's thought to start.
Yeah, very. It's really a change in our thinking about Parkinson's disease that we've discussed at this conference before in terms of this sort of progression and things like that as well. So absolutely. All right, Dr. Jacob, back to you. We had a question about the responsiveness of a patient to medication in Parkinson's disease, and is there a time at which a patient loses responsiveness to the medicine for Parkinson's disease? And in a related question, is that someone that would be a good candidate for deep brain stimulation or surgical therapies of Parkinson's?
That's a great question, and one that I talk to patients about a lot. So over time, as Maureen had said, we know that this disease progresses. And often when it progresses, we have to change your medicine, right? So we have to increase medicines over time. We may have to give medicines more frequently over time. The medicine seems maybe like it's not working as well over time. Well, we know that the medicine doesn't, in effect, stop working. It usually, the mechanism of that drug is the same. It's not like you build tolerance up to it and you need more and more and more. But because those cells that are producing dopamine are being lost over time, you're needing to increase your medicine over time to offset that, maybe increase the dose or increase the frequency of timing. Now, sometimes as time goes on, what happens is we run into, say, side effects, or people get intolerable dyskinesias, or say they're having to take the medicine so frequently and it's still wearing off. And so this really disrupts people's lives. And so that is the point usually when we start talking about alternative therapies like deep brain stimulation. So something that will treat symptoms of Parkinson's. It doesn't cure Parkinson's or reverse Parkinson's, but it's another symptomatic treatment that allows us to treat your symptoms without having to add more medication that may lead to more side effects, and that helps with the wearing off or motor fluctuations we often see with Parkinson's over time. So again, if you have those complications with therapy over time with Parkinson's, you may be a candidate for DBS. We usually like to wait at least 5 years into Parkinson's before considering DBS, just in case we may be dealing with an atypical Parkinson's that may not be so clear early on. So usually at least a 5-year window. And then some patients who might not be good candidates for DBS are ones that have significant cognitive impairment or dementia. So that may be an exclusionary criteria for DBS. But otherwise, if somebody's had Parkinson's for a while, the medicine, they're having complications from medicine, side effects, and motor fluctuations, those would be the patients that would be a good candidate for DBS surgery.
And
I want to add. A lot of people ask me, well, how come you keep adding another medicine, you know? And so I've come to think about dopamine metabolism as kind of like a target. And, you know, if you're a really good person with a bow and arrow, you can hit the target straight on, right? So that's your Cinemet. But you might be a little off, or you're trying to hit it at an angle. That's where the other meds come in different parts of the dopamine metabolism. So we're attacking it from a different avenue to, again, get more benefit.
No, I think that's important. Just a follow-up, actually, question, Cara. You mentioned atypical Parkinsonism. That's something that we've talked at previous symposiums, but I think maybe just a short statement about what is atypical Parkinsonism. 'Cause people
Yeah,
hear that.
so when we see patients and we see signs of Parkinson's, you'll hear us use the term Parkinsonism, right, to define these are symptoms that look like Parkinsonism. And there's many diseases that fall under that big umbrella term of Parkinsonism. One is idiopathic Parkinson's disease, which we've talked about mainly here today, but there are other I refer to them as cousins of Parkinson's, where they may have more atypical features. So some patients, you may have heard of people having multiple system atrophy or progressive supranuclear palsy or even dementia with Lewy bodies. These are all cousins to Parkinson's in a way that they may have Parkinsonian features, but then they have additional features that lead to those diagnoses. I don't know if you want me to go into the details of each of those, but.
No, I don't. I think that's probably beyond the scope of the panel question, but I think, yeah, that's an excellent explanation. Ultimately, what I've really come to understand is that there's pathology in the brain in terms of, alpha-synuclein or tau or other sorts of pathologies in the brain. But what matters in terms of how it expresses its symptoms is where that pathology is located in the brain. And so you can have similar symptoms because there's two different types of pathologies that happen to affect the same circuit in the brain. But they're going to be treated very differently. Parkinson's disease is a problem where there's not enough dopamine. You're going to treat it with dopamine, whereas within the atypical Parkinsonisms, even though the problem is in the same circuit and you get the same kind of symptoms in much the same way, it's not going to respond as well to the dopamine. So both of those things are critical. What's the pathology? What's the underlying changes that are happening in the brain? And then also, where in the brain is that happening? So thank you. Dr. Sawyer, there was a question about sleep and how much sleep is helpful at night, and is it okay to nap? And if so, how much napping is okay?
Yeah, this is a really common question that I get because the pervasive thinking, at least in the population, is more sleep is better, and really more sleep meaning if you're over the age of, we'll say 55, you should be getting 7 to 8 hours of consolidated sleep, meaning sleep that's occurring at the same time every night. Beyond that, we have to start evaluating for, is there an underlying sleep problem? Why are you sleeping 9, 10 hours at a time? So what I tell people is our goal is to get you to 7 or 8 hours of consolidated sleep at one time. When you take naps during the day, if you sleep for 2 hours in the middle of the afternoon, that may be detracting from the quality of sleep that you're getting later on. So I have people that say, yeah, I sleep 8 hours at night. I take a 2-hour nap in the middle of the afternoon. That means that 8 hours at night isn't the quality of sleep that we want it to be. And that has to do with the certain cycles that your brain goes through as part of normal sleep. We talked about in sort of the deeper stages of sleep is when we get that restorative property. So I tell people, if you're going to take a nap, let's aim for reducing the nap to less than 30 minutes during the daytime. And this is something that we do over a long period of time because people develop their sleep habits throughout their lifetime, and then I'm asking for a sudden change. No, I say, let's do this slowly and looking at other things that could be causing inefficient sleep.
Excellent. Thank you, sir. Question for Dr. Seroogy. So we know that the pathology of Parkinson's disease is affected in the brain cells by many things. What can you tell us about growth factors in the brain, and how would they play a role in terms of how Parkinson's might develop or progress?
Right. Yeah, that's a good question, and a lot of basic research has gone into this over the years. But so growth factors basically are proteins or some sort of biochemicals that promote the health of nerve cells or other cells in the body, especially during development, so the cells make the right connections, but also in the adult brain, and particularly after injury. So the thought was, say, for example, in Parkinson's, which has been shown that certain growth factors, one called BDNF, let's call it BDNF, is lower in Parkinson patients in the dopamine cells, in the region of the dopamine cells and its connections, than in non-Parkinson patients. So perhaps you could replenish that growth factor in the brain, whether by injection or through the blood, or that would help promote the survival of the cells or be some sort of disease-modifying treatment, meaning that you don't just, that you can stop or slow the progression and not just have a treatment, right? So there have been a couple clinical trials that have not worked, and I think a lot of it is because of delivery. These growth factors are usually big proteins, so they can't pass through the blood-brain barrier, so they can't get through to the brain, right? And then even if you inject them into the brain, you inject it into some of the cavities, the water-filled cavities in the brain, then they bind to receptors that line that, and they still can't get into the part where you want to get them in. So I think it's a question of delivery, but a lot of work needs to be done, I think, more in that. And organizations like the Michael J. Fox Foundation are promoting growth factors as part of another therapy, as a kind of an add-on to other therapies that are being developed. So kind of the bottom line is, I think they're promising. They probably aren't going to be the panacea that people thought in the past, but I think they're going to prove to be very valuable as kind of a co-treatment in the future for Parkinson's.
Thank you. So one of the things that we really try to focus on at these symposiums is the power of movement, the power of exercise. Question for you, Josefa. So is there a way that you can help people here? What's the best way to motivate a person to start exercise and maintain exercise, both from the patient standpoint, and then also a lot of times the caregiver wants to try to motivate their spouse to exercise, but they're having difficulty. Do you have any tips or tricks that you've encountered in your practice?
I think that's the ultimate challenge, because we're trying to change behavior and try to motivate someone that already has all these non-motor issues going on, depression, apathy, and, dealing with everything that you're managing in daily life, and convincing them now, by the way, you have to exercise every single day. So I think for me as a professional, that is the difficult challenge. I do receive a lot of people from different parts of the country and also from other countries, and so it really depends on the person that I have in front of me, and what type of job did he have, what is he willing to give, I wouldn't say give up or to, how much does he want to improve or not, right? So I do have, like, for example, the exercise of shame, which is, for example, if you don't do this, you are the most pathetic person ever, which is like, imagine, I want you to sit and stand twice. This is how desperate I get trying to resolve these problems, right? So I am blessed with some creativity, so I do try to see anything that they are doing, and then try to add on these specific ingredients that I mentioned that we need in terms of exercise. So you can have something, some kind of activity. Maybe we don't want to call it exercise, but it's more important to keep our level of activities, right? So even if you like washing the dishes, can we add in something while you're doing that, while you're brushing your teeth? I think those are the very easy ways to convince someone to do it. And then I tend to see that people over 80 are actually quite obedient, so they actually do the exercise we prescribe. 80, 90, they're really, those are the most disciplined ones. But then, convincing someone that just got diagnosed and now you have to make this life-changing situation, 60, 70, those are the most behaved. I think that those are more just difficult. I mean, there's a lot of strategies that I could think of, specifically for each case, but what combines it all, I would say the element of enjoyment and really finding something that you like, but really making it also specific. So it's not only the fun, but the fun will really help you keep going and doing it and coming back. And changing variety as well, changing the activities that we do also helps us to keep motivated. So.
Yeah. No, I think that's excellent advice. I think just like what Dr. Sawyer was saying with his presentation, you have to find something that you love to do. That's the best exercise. It's not Tai Chi. It's not, unless you love Tai Chi, it's not, this exercise bike or this exercise bike. It's finding something that you can, feel passionate about and continue with. So that's the best exercise.
Andy, could I just jump in? Also,
Please.
it's been shown that repeatedly that exercise increases these beneficial growth factors in different parts of the brain. So that's just another benefit.
Absolutely, yeah.
Can I add something too? I found if the person with Parkinson's really commits themselves for like 3 months, I ask my patients when I see them, give it 3 months. They feel better. And then they're hooked too.
It's those natural endorphins kicking in. Dr. Jacob, this is relevant to, I think, to your talk a little bit because it's Parkinson's in the press, I guess, a little bit. So we're seeing commercials that say 50% of people with Parkinson's disease have hallucinations or will get hallucinations. Is this true or is this a myth? And what are the ramifications of the different kinds of hallucinations in Parkinson's disease?
Sure. So there is truth in some of that a large number of our patients do get hallucinations. It's usually later on in the course of the disease. The hallucinations vary, right? So most of our patients have maybe some mild, non-threatening hallucinations or illusions. So a mailbox from afar will look like a person, or they'll say they see a shadow out of the corner of their eye and they look and nothing is there. So those are very mild, non-bothersome hallucinations. So that's grouped into that kind of 50% that commercial is claiming. Now, we do have some patients that have threatening and bothersome hallucinations, which we can usually treat effectively with medication. So there are treatments for those if they do become threatening or scary to the patient. So I know what commercial they're talking about, and I'll tell you, I think that commercial scares the living daylights out of everybody. I've had so many patients ask about the commercial, and it's really kind of creepy and depressing, that commercial. But honestly, it's not, I think it causes more alarm than it should, to be honest with you. A lot of the hallucinations we see in Parkinson's are very, very manageable. And not bothersome. And even if they are scary, we can often get you on the right medicine or adjust things so that we can control those.
Yeah, no, I think when you're talking about the 50% number, you're including everything, including illusions like what Cara says, or see something out of the corner of your eye and you turn and something is not there. I think that's what they're including in the 50%, which I think is fair. I mean, that's along the spectrum of hallucinations, and it probably is related to how Parkinson's is affecting your perception of reality. But that doesn't mean that they're all going to be the snakes coming out of your mouth and things like that. I don't think I've ever had someone tell me that they had a hallucination of a snake coming out of their mouth. So, Dr. Sawyer, so this patient has a question. I have trouble remembering things. My wife gives me cues, and then I can remember it. Is this common in Parkinson's disease? And if so, how could I use this to my advantage?
Go for it.
Yeah, that's a big question. I find that it's extremely common, and actually more the converse. The one that I tend to get is I'm either having trouble coming up with a word or I'm having trouble remembering something, and the spouse is asking me, do I give them a cue or do I make their brain work, sort of the exercise principle, and they will get it and that's healthier for them. I always tell people it's not healthier to make the person work, and if they would benefit from the cue, give them that cue. If you know what word they're trying to say and they can't say it, give them that word. There's no benefit to them, to the person sitting there struggling. And I think it's very important to integrate that into your day-to-day life. If somebody is very responsive to cueing, figure out ways that we can do that. I have patients that use Post-it notes sort of on what I'm supposed to do in my daily routine, and they're just sort of Post-it noted around the house, which I've seen the pictures where it's like, okay, you finished brushing your teeth, now go downstairs, and it has a little arrow pointing where downstairs is. And the person is actually functioning a lot better than I would have expected, and I think it's because they're using these cues. So I think it's definitely something that can help on the day-to-day life, and I would advocate for that. Don't ever, if you're seeing people struggle, don't ever make them work for it cognitively, that's not something that's beneficial. And that may just be frustrating for you as the caregiver and them as the patient, would what I would say.
Yeah, that's actually one of the hallmarks of cognitive impairment in Parkinson's is that you can get memory in, but it's getting it out that's hard. And so those cues can be amazingly helpful. So using those tricks, I think, are great. All right, well, we have a million other cards, actually, and I'm sorry we weren't able to get to all of them, but I think we've come to the time of the end of our panel question and answer. I really wanted to thank our panel participants here for giving of their time and their expertise to help answer your questions, and really wanted to thank you all for coming. We have some concluding remarks, so don't go anywhere just yet. I think